So hello friends, this is the second session for question and answers on adrenals. So I'm Dr. Santosh Abraham. I'm working in Scarborough General Hospital as a specialist registrar in endocrinology. So I will discuss today around 15 to 18 questions. I know that these questions are a bit complex, so I want you to think about the guidelines which I've discussed before and to apply these guidelines to these clinical contexts. And these questions are quite similar to the questions which you will find in the SCE exam. So the first question is about a 40-year-old man who is currently on hydrocortisone 20 milligram in the morning and 10 milligram afternoon. So he was diagnosed to have adrenal insufficiency 15 years ago, and hence he was started on this dose of hydrocortisone. He is also having fludrocortisone 0.1 milligram every morning. Now he presents with intense muscle weakness and spastic legs. So a person who has been diagnosed with adrenal insufficiency 15 years ago, who is on replacement glucocorticoids, now has intense muscle weakness and spastic legs. So what is the diagnosis? Is it serotonin syndrome, GH deficiency, adrenal leukodystrophy, or Zellweger syndrome? So the right answer is adrenal leukodystrophy, as serotonin syndrome, GH deficiency and Zellweger syndrome does not cause the adrenal insufficiency. So adrenal leukodystrophy is a X-linked disorder, and it causes malfunction of the adrenal cortex and demyelination of the CNS. So it is characterized by defective beta oxidation of very long chain fatty acids, VLCFA. So accumulation of VLCFA in the brain, adrenal cortex, testis and liver produces the clinical manifestation of this disease. So it should be always considered as an etiology of adrenal insufficiency in a young man under the age of 40, especially in the absence of adrenal antibodies. So insufficiency or neurological problems alone can be the presenting complaint of adrenal leukodystrophy. Although in young adults, adrenal insufficiency is often preceded by progressive neurological symptoms. So in this person, he's got a history of adrenal insufficiency, and now he's presenting with muscle weakness and spastic legs. So for the above patient, defect in which of the following will explain the findings? As I've told you, very long chain fatty acids accumulate in the brain, adrenal cortex and testis because of the defective oxidation of VLCFA. So VLCFA is the answer here. What about somatostatin C? It is also known as insulin-like growth factor, IGF-1. So it is mainly produced by the liver in response to GH stimulation, and it is a surrogate marker for GH hormone excess actually. So, but it is not a reliable marker to diagnose the growth hormone deficiency, although we do screening with IGF. GH deficiency can also present with muscle weakness, but no spasticity has been documented, so this cannot explain the patient's symptoms. What about serotonin? It's a neurotransmitter, and it is found in neurons in the raphe nuclei. So it plays a major role in sleep-wake cycles, emotions, etc. So the receptors for serotonin have role in multiple psychiatric and medical conditions, including depression and anxiety. So serotonin levels the brain has been associated with the treatment of these conditions when they are modified. But if there is a supraoptic level of serotonin, this increased level of serotonin can overstimulate serotonin receptors and cause the serotonin syndrome. So it is mainly due to the overstimulation of 5-HT1 alpha receptors. So it presents as a triad of sudden onset of cognitive changes, autonomic instability, and neuromuscular changes. So it can include hypothermia, tachycardia, diaphoresis, confusion, hyperreflexia, rigidity, agitation, restlessness, finally coma, and even diarrhea, nausea, and flushing. So the onset of symptoms can vary. So it usually occurs within 24 hours of an increased dosage of serotonin increasing medications. So fluoxetine and other SSRIs usually cause this. So this patient does not have any psychiatric history or any history of SSRI intake, so serotonin is out of the question. And hydrocortisone is not a practical approach. So it cannot be measured. It can be measured, but measuring hydrocortisone, it's not a practical approach because it is converted to cortisol in the body. So the second question is about a 60-year-old man. He has a history of small cell carcinoma which was treated by chemotherapy 5 years ago and is in remission. So he was started on fentanyl 75 mg as a transdermal patch 1 year before due to the pain. He's also on dabigatran for DVT, and he had a recent hemorrhage, and hence he's admitted to the hospital. So you are seeing him, and he's having significant persistent hypotension, weakness, and fatigue. So he has had decreased libido in the past. So physical examination is unremarkable. So we measured a morning cortisol, which was found to be very low, and the synactin test did not raise the cortisol, and the ACTH level is also low. So morning cortisol was low, synactin failed to raise the cortisol, and ACTH level is also low. So what is the reason for the adrenal insufficiency? So clearly you can see that this is ACTH independent adrenal insufficiency. So is it mets to the pituitary gland? Is it mets to the adrenal gland or adrenal gland mets? Or is it hemorrhage in the pituitary? Or is it due to the new medication which we have started? So we can see that there is no headache, no visual complaints, or no other hormonal deficiencies except this hypotension and low ACTH. So hence it is very unlikely that this patient will have any pituitary hemorrhage. Also, since the lymphoma is in remission and there is no history of weight loss, it is unlikely that there are mets to pituitary or to the adrenals. But opioids and opiates inhibit this HPA axis at multiple levels. So there are reduced concentrations of CRH, corticotropin releasing hormone, and vasopressin, and hence the ACTH is also reduced from pituitary in opioid in persons who take opioids and opiates. So the capacity of the pituitary to respond to stimulation as well as directly interfere with the direct adrenal gland production of cortisol and DHA is affected. So morphine and fentanyl patches are known to cause this effect. Even tramadol and methadone are also associated with the adrenal insufficiency. So the opioid induced inhibition of the HPA is the reason for this adrenal insufficiency. So the fentanyl patch is the answer here. So we have a 48-year-old female in this question who has a history of metastatic melanoma. So she is receiving ipilimumab, which is a monoclonal antibody. So it is a CTLA4 antagonist. So in other words, it is cytotoxic T lymphocyte antigen antagonist. So this lady is receiving this ipilimumab, CTLA4 antagonist. She has had the 3 doses and she is now presenting with weakness, fatigue and headache. So the blood workup show that she's got low cortisol and low ACTH, and CT shows pituitary enlargement, and also an abdominal CT shows bilateral enlargement of the adrenals. So the question is, why is this patient having adrenal insufficiency? Is it due to any mets to the pituitary from the melanoma, or is it due to any mets to the adrenal from the melanoma, or is it a side effect of the ipilimumab causing hypophysitis and adrenalitis, or is it something else? That is it none of the above? So the answer is hypophysitis and adrenalitis caused by ipilimumab, because mets to the pituitary and adrenals will not involve these glands diffusely. In the CT, you will have the nodular appearance. So ipilimumab is, as I told you, is a humanized monoclonal antibody that works against CTLA4. So CTLA4 actually negatively regulates T cell responses. So it is used in the chemotherapy, but a treatment for the CTLA4 antagonist is that it can produce hypophysitis. So it is the most common endocrinopathy related to this anti-CTLA4 treatment. So it presents as either pan-hypopituitarism or isolated anterior pituitary hormone deficiency, with secondary adrenal insufficiency being the most common, with or without pituitary enlargement. So it could again present as pan-hypopituitarism or isolated anterior pituitary hormone deficiency with secondary adrenal insufficiency. So between 5 to 36 weeks, this hypophysitis can set in, and even if you discontinue the ipilimumab, it does not result in the resolution of secondary adrenal insufficiency. So you need steroid replacement in these patients. Some patients have shown suboptimal improvement in the symptoms despite steroid replacement. So, but some studies have shown that these patients might be even suffering from primary adrenal insufficiency as well, because ipilimumab is also known to cause autoimmune adrenalitis. So ipilimumab causes autoimmune adrenalitis as well as hypophysitis. So that's why choice 3 is the answer. It could also result in the enlargement of both adrenal glands and pituitary in a diffuse way. So next question is about a 20-year-old lady who comes with complaints of hirsutism. So she is really concerned about it. She's frustrated and depressed. She tried different methods to remove the hair, like lasers, plucking, waxing, but it doesn't work for her. So her menstrual periods are regular and she has no acne or hair loss or change in voice. Sexually, she's active and she's got a boyfriend, but she's not planning for any pregnancy. Not on any medications. Her BMI is 30, so she's overweight, and she has increased terminal hair on her upper lip, chin, arms, and legs, quite typical of the the hirsutism pattern. And her Ferryman-Galway score, which is an index for hirsutism, is 16. So, which is the next best step in the management? No further workup is necessary. Go for a plasma testosterone, and a DHEAS, a plasma testosterone, DHEAS, and 17-hydroxyprogesterone. So anyway, this lady needs further workup. So the first choice is wrong. So the next choice, you have the plasma testosterone plus the DHEAS and plus 17 OHP. So her Ferryman-Galway score shows that she has got moderate to severe hirsutism. So here you have to test for the elevated androgen levels, especially if the hirsutism is of sudden onset or it is rapidly progressive. So it can be an increasing indication of an underlying medical disorder, and also it could have implications for fertility. So this patient has got isolated moderate hirsutism. She has normal periods and is devoid of other signs of symptoms of hyperandrogenemia. So the best test is to do an order plasma total testosterone level. So some of them advocate that free testosterone should be done. This is because elevated androgens could suppress SHBG, the sex hormone binding globulin. One could also check for the 17 OHP if there is concern about the congenital adrenal hyperplasia. But the first line will be doing a plasma testosterone. Serum DHEAS, even if you measure, it does not change the management in mild to moderate hirsutism. So that is why we go for with the plasma testosterone first. So what is hirsutism? It is excessive terminal hair that appears in a male pattern in women. So Ferryman-Galway score is used to assess the hirsutism. So I mean the pattern of hair growth. So if it is above 8 or equal to 8, then the person will be having a hirsutism. So it is based on the 9 areas of assessment, the Ferryman-Galway, like upper lip, chin, chest, abdomen, pubic area, arms, legs, upper back, lower back, or buttocks. And each area is being graded 0 to 4 based on the severity of terminal hair growth. So 0 means there is no hair, and 4 means it's frankly virile. So it's based on that. So anything above 8 will constitute hirsutism, and if it is more than 15, it is moderate to severe hirsutism. So you measure the serum testosterone, and it is in the top normal range. That is, the normal range is 45, so it is near the top. So how will you treat this patient? So will you give the OCPs, or will you give a 0.25 dex at night, or will you start with finasteride or metformin, or will you give a GnRH agonist? So in the management of hirsutism, there are two options. One option is that you could remove the hair, but it doesn't work for her, and the other option is giving medications. So here the patient's hirsutism is causing significant distress, and so a pharmacological approach is reasonable here. So hirsutism is dependent on circulating androgen concentrations. So serum androgen levels do not have to be frankly elevated. So OCPs, they reduce the serum androgens by a number of mechanisms, such as suppression of LH and also stimulation of SHBG with increased androgen binding. So the SHBG will bind the androgen more, so it will result in decreased free androgen levels, and there is a slight blocking of the androgen binding to its receptor by the OCP. So DEX is not administered because there is no evidence to suggest that this patient has CAH. So DEX is given when there is CAH to reduce the androgen production, and they have only mild effect on hirsutism. And what about finasteride? Finasteride is an anti-androgen, and it is not recommended here. It inhibits 5-alpha reductase activity and has been shown to reduce hirsutism score, because this woman is not using any adequate contraception. So finasteride, being an anti-androgen, is not recommended here. Metformin is not effective for hirsutism, so it's not the right answer here. So GnRH agonists are similar in efficacy to the OCPs, but they are not recommended here because they are expensive, and also they lead to severe estrogen deficiency with resultant postmenopausal symptoms. Even though they suppress the LH, they are not recommended here because they will result in estrogen deficiency. So coming to the next question. This is about a 60-year-old female. So she had a menopause at 51. Now she is complaining about hirsutism, which is worsening, and she needs frequent shaving every other day. So she's got also hair thinning and has emotional lability and has got deepening of her voice. Her past history includes hypertension and type 2 diabetes mellitus on metformin and mixed insulin. Also, she's obese and she's got hyperlipidemia. So she's got that metabolic syndrome constellation, but she's got no history of PCOS or any infertility. So on physical examination, she's got a deep voice. She has facial, chest and abdominal hair, and Fermin Galway score is 20, so it's like very severe hirsutism. But there is no scarring of the scalp hair. She's got thinning and hair distribution in a male pattern, and it's got centripetal obesity and abdominal stretch marks too. So she's got that metabolic constellation with male pattern of hirsutism, in short, with centripetal obesity and abdominal stretch marks also. So what will you do in her case? Will you do a 24-hour urinary free cortisol, or plasma androstenedione, or a transvaginal ultrasound, or a plasma testosterone DHEAS, or the plasma testosterone DHEAS and 17 OHP? So this patient has significant signs and symptoms of hyperandrogenism, including hirsutism, alopecia, and deepening of the voice. So it is appropriate to measure the plasma testosterone and the DHEAS levels. So hyperandrogenism after menopause is relatively uncommon. So the most common causes for this is an ovarian hypertrichosis or androgen secreting tumors of the adrenals or ovaries. Less likely will be PCOS and non-classical CAH. Cushing syndrome, acromegaly, hyperprolactinemias are also rare causes of this. So what about 24-hour urinary free cortisol? It is used for the screening of Cushing's disease. So Cushing's disease can increase androgen levels by excessive ACTH. But in this case, this patient not only shows hirsutism, but she's also got virilization. So in Cushing's disease, you have hirsutism, but they are not virilized to this extent. Given the Ferryman-Galway score of 20. So and this patient does not have any other symptoms of Cushing's, such as proximal muscle weakness, EC bruisability, or violaceous striae. And what about option B? Testosterone is a better marker of androgen production in women, so it is not recommended. So, and what about option C? So option C is incorrect, because imaging should only occur after documenting significant elevations in serum testosterone or DHEAS. So imaging of the ovaries is performed if the serum testosterone is greater than 150 nanogram per deciliter. If ovarian imaging is negative or the serum DHEAS is greater than 700 milligram, then adrenal glands should be imaged. So you want to look for the plasma testosterone as well as for the DHEAS. So DHEAS is a better measure of adrenal androgen production, and these are converted to androstenedione and then to testosterone. So ideally you need to look for the DHEAS also with such such rapidly progressing hirsutism. So if the testosterone is above 150 nanogram per deciliter, and if the DHEAS is above 700 milligram, you then proceed with imaging. So what about the last option, including 17 OHP? So it is incorrect, because it will be a rare case, rare for a case of the non-classical adrenal hyperplasia to present like this, in the postmenopause. So almost all the cases of NCH are diagnosed before menopause. So it's very rare. So you just need to do the plasma testosterone and the DHEAS in this patient. So her labs show that the plasma testosterone is significantly elevated. It's 352 now, and her LH is 27.5. It's normal, and the FSH is 51.2, and the DHA is low. It's 33. So what is the next step here? Will you go with a bilateral oophorectomy, a transvaginal ultrasound, or will you start with spironolactone or a gonadotropin releasing hormone agonist, GnRH agonist, or a CT abdomen? So ideally you will go for with a transvaginal ultrasound, because the testosterone is exceeding above 150. So imaging of the ovaries should be performed. So there is a high risk that this could be an androgen secreting ovarian tumor. So it could be done, the screening is done by a transvaginal ultrasound. MRI of the pelvis can also be done. But the serum DHAs in this patient is normal, so there is no need to image the adrenals. If the DHAs were greater than 700, or if the ovarian imaging was negative, you could proceed with adrenal imaging. So the CT abdomen is not a right option here. What about C and D? Because this patient will require imaging before treatment, and spironolactone will not be effective for this level of hyperandrogenemia. Her androgens are really raised. What about the GnRH? So it will suppress the LH. So in patients who are not suitable for surgery, it's been used. So her imaging was normal. No ovarian or adrenal masses and no enlargement of the ovaries were observed. So which of the following is the next best step in the management? Will you go for a bilateral oophorectomy, which will go for the ovarian venous sampling, or repeat imaging in 3 months, or will you give a trial of spironolactone? So this androgen secreting tumors of the ovaries can be sometimes very small, that they will not be picked up on imaging. So they tend to be slow growing. Therefore, even if a repeat imaging is done, it will not be helpful. So a repeat imaging in 3 months is out of question. And what about ovarian venous sampling? It is not usually preferred because it is inaccurate and it can give misleading results. What about spironolactone? So we don't know the etiology of her excess androgen, so it is unlikely to be effective. So, but we know that this is coming from the ovaries and it is not from the adrenal. So basically we will go with the bilateral oophorectomy. So this patient is declining surgery and she wants to try some medicines instead. So what will you give her? So will you give her spironolactone in a high dose, or will you give her topical eflornithine, or will you give high dose spironolactone plus eflornithine, or a laser treatment, or a GnRH analog? So clearly laser treatment will not be effective because she's tried, I think, and it doesn't help her. And also it doesn't help her symptoms also. What about spironolactone? So spironolactone is an aldosterone agonist, and that exhibits competitive inhibition of the androgen receptor as well as inhibition of 5-alpha reductase activity. So, but it is not the best choice here because it is not likely to be effective given this patient's degree of virilization. So this patient is really virilized to a great extent, so spironolactone is not going to be effective here. And eflornithine is an inhibitor of hair growth, but it is indicated only for facial hirsutism, so it is not going to help here as well. And it also will not help with other signs and symptoms of hyperandrogenemia. And for the same reason, you know, the third option also will not work for her. So then what? So leuprolide or GnRH agonist can be administered in this case, you know, which will help with her symptoms. So this GnRH analogs, they lead to the down regulation of the GnRH receptor at the pituitary level, and hence the LH falls and the FSH also falls. So the ovarian testosterone production is always dependent on the LH. So since the LH falls, the testosterone also will fall. So chronic administration of this GnRH analog has been shown to be safe and effective, and in women with androgen secreting lesions of the ovaries. So here it is a reasonable choice for this woman who doesn't want a surgery. So let's go to the next question. It's about a 28-year-old Hispanic lady who's got irregular menses. She's got hirsutism and obesity. So her first period was at 14, and ever since she's been always having irregular menses with variable cycles and more often missed months. So she has hirsutism on her upper lip, chin and breast, and her Ferriman-Galway score is 17. So she just got married and would like to get pregnant within the next year. She's having unprotected intercourse with her husband. You order a serum prolactin level and it is normal. You also order the testosterone and DHAS levels, so they are mildly elevated. So what is your next step in the management of this lady? So with irregular menses, hirsutism and obesity, with irregular periods, with a moderate to severe score of Ferriman-Galway, and also she's married and she would like to get pregnant. So prolactin is normal and mildly elevated serum testosterone and DHAS level. So what will be your next step? Will you image the adrenals and ovaries? Will you order clomiphene citrate? Will you ask her to advise? Will you ask her to lose weight and repeat the labs in a few months? Or will you go for a LH-FSH ratio, or will you go for a 17 OHP levels? So what about option A? It is not indicated here because you know, it's only marginally elevated, her testosterone and her DHEAS. So you know, there is no point in doing the adrenals and ovaries imaging, because you do it when the testosterone is more than 150 and the DHEAS is more than 700. The imaging, like if the testosterone is more than 150, you image the ovaries, and if the DHEAS is more than 700, you image the adrenals. So what about clomiphene? her periods are irregular, but she's not trying to get pregnant. So so clomiphene would not be the first choice here. So what about the main differentials here? The differentials will be the PCOS and the classic 21 hydroxylase deficiency. So you need to rule out both of these conditions here. So basically you do a 17 OHP level to rule out the CAH, and also PCOS, it's a clinical diagnosis based on the symptoms. Here the LH-FSH ratio is quite variable and cannot be diagnostic of PCOS, so you can rule out that. And weight loss can be helpful to decrease the serum androgen levels, but you don't know the diagnosis yet. So a 17 OHP is a simple test which could help you to rule out CAH. So talking about CAH, as I've told you before, it's one of the most common autosomal recessive disorders. So the most common form is 21 hydroxylase. There are three forms of 21 hydroxylase deficiency. One is classic salt wasting, one is simple virilizing, and then the other one is non-classical CAH. So females with classic salt wasting or simple virilizing forms usually present as babies with ambiguous genitalia. Males with classic salt wasting present with neonatal salt wasting crisis. So it could manifest as increased potassium, low sodium, and failure to thrive. So with the non-salt wasting pattern, males could present with early virilization. But you have neonatal screening now, which will so many cases of the 21 hydroxylase deficiency is diagnosed now. So the disease severity is correlated with the effect of the mutation on 21 hydroxylase. So if there is a complete loss of the enzymatic activity, or if it is only partial loss. So the clinical presentation is indistinguishable from PCOS. So all women with features of PCOS should be screened for non-classic 21 hydroxylase deficiency by checking an early follicular phase 17 hydroxyprogesterone level. So this follicular phase 17 hydroxyprogesterone level is very important. So you just need to rule out this NCAH here. So levels greater than 200 to 400 are diagnostic. So if the levels are borderline, you should do a cause-entropin stimulation. Post-stimulation, there's an exaggerated response and the levels are greater than 1000 nanogram per deciliter usually. So follicular, so you will do the 17 OHP here. And her 17 OHP comes to as 196. So what is the next step in her management? So as you can see, the 17 OHP is in the borderline state. So it's better to go with the cause-entropin test. So if the level rises to greater than 1000 nanogram per deciliter, it is again diagnostic of the non-classic congenital hyperplasia. Congenital adrenal hyperplasia. So she's asking you what can be done to improve her chance of conceiving and improving her hirsutism. So which of the following will you recommend? So is it metformin? Is it clomiphene? It is dex. Is it clomiphene and metformin? Or will you counsel her on the weight loss and exercise? So metformin, clomiphene are used for PCOS actually. So her symptoms are not very much consistent with hirsutism. So the answer here is dexamethasone. So this lower dose dexamethasone, since we are suspecting that she is having non-classical form of CAH, will be effective in correcting the irregular menses and hirsutism. And how about counseling her weight loss? It is useful, especially to treat an ovulation in women with PCOS, but it is not the best answer here. So you have in the next question, you have a 50-year-old lady complaining of rapid weight gain and excess facial and abdominal hair for the past few months. So the weight gain has been mostly in the face and abdominal area. The last menstrual period was 3 months before, and the menses before that were regular. She's got fatigue and she's only on oral contraceptives. So on examination you find that she has got facial and abdominal hirsutism, as well as facial fullness also, with a small dose of cervical fat pad and supraclavicular fullness. So she's got Cushing out features with hirsutism, and her Ferryman-Galway score is also 18. So that indicates moderate or even severe hirsutism. So what will be her next step in the management? So 24-hour urinary free cortisol, plasma testosterone and DHEAS levels, or will you do a 1 milligram dexamethasone suppression test, a plasma testosterone level and the DHEAS, or only the free cortisols, or will you go for the imaging CT abdomen, or will you do a AM cortisol level, plasma testosterone, DHEAS levels and 17 hydroxyprogesterone levels? So what will be the diagnosis here? So there is a rapid development of hirsutism and Cushing-oid appearance. So there is a chance that it could be an adrenal cortical carcinoma. So this adrenal cortical carcinomas, they secrete both cortisols and androgens in 1/4 of the cases. So you would basically check for a urine free cortisol 24-hour, a plasma testosterone and the DHEAS levels. So answer option A is the right answer. What about the second one? Because the oral contraceptives can cause a false positive dexamethasone suppression test, so you won't opt for the second one. And what about the third one? So here you need to assess for the cortisol and the androgen. So the UFC will only be a screening for Cushing's, since she's got the rapid development and of her hirsutism and her change, her appearance. She needs evaluation of all the three. And what about CT? Imaging will always follow once the biochemical investigations have been done. But here, since the given the rapid onset and progression, acute onset and rapid progression, imaging of the adrenals will be justified. But biochemical workup is important first. And what about the AM cortisol level? It is not appropriate because it will not show the hypercortisolemia, and also she is on the OCP, so it can cause a elevation in the serum cortisol. So any patient with the or OCPs, you proceed with the 24-hour urine free cortisol. And will you look for a 17 OHP? No, because 17 OHP is more likely to have a chronic onset, and here it is of a sudden onset, and in NCH you will have a slow progression of the symptoms. So her labs shows the urinary cortisol is 202, so which is markedly raised, and DHEAS is 890, that's also markedly raised. So when you have this cortisol elevated and the DHEAS elevated, you could think about something about the adrenals, in fact, and the testosterone is also found to be elevated. Okay, so we are now thinking about something about the adrenal tumor. So what about the CT now? The CT shows a 5 centimeter right adrenal mass, that is with 38 HU, and it exhibits poor washout on delayed contrast enhancement. So what does that mean? A CT with a 5 centimeter adrenal mass with 38 HU and exhibiting poor washout with delayed contrast. So that means that it's a carcinoma. So what will be the next step? Will you do an MRI? Will you do an MIBG to roll out the pheochromocytoma? Or will you do a biopsy of the adrenal mass? Or will you do the right adrenalectomy? So you're not going to do the MRI because already you got the diagnosis now. Now, what about the MIBG? No, because it's not indicative of not a pheochromocytoma. And a cytology, the biopsy is really contraindicated, and it cannot distinguish between adrenal mass and adrenal carcinoma. So you will proceed with the right adrenalectomy here. So the next patient is a 63-year-old female patient. So she is having weight gain, facial hair, and facial acne. So she's having also some non-specific abdominal pain for the past 5 months. So her blood pressure is elevated. She's got Cushingoid features, including white purple stray and notable hirsutism. So then we did a screening for her since she has the Cushingoid features, and cortisol is found to be elevated. DHEAS is also 880. I'm sorry, I think the data for this patient is not sufficient here to make a diagnosis. I think there was some error. Anyway, I will review this question again, and I'll come back. So the next patient is a patient who's come with an adrenal incidentoma. So he presented with a painful hematuria, so they did a non-contrast CT, and it showed a kidney stone, but it also showed a 3.5 centimeter adrenal mass with 30 Hounsfield units. So he's got a 20-pound weight loss also. So he has no history of any hypertension. He's been a smoker for the past 50 years. He only takes multivitamins. So the BMI is less, 20. I mean, it's normal, but it's more towards the lower side. So he's got that weight loss. Probably it could be the reason. And the blood pressure, the heart rate, everything is okay. He appears thin. The physical examination does not reveal anything significant. So what will you do in this patient? Will you proceed with an MRI, or will you do an FNAC, or will you do a serum DHAS, or will you do the plasma-free nephrins, or will you go directly for the right adrenalectomy? So this adrenal mass, you can see that the size is 3.5, and so it's on the borderline, it's nearly 4, and she's got a high Hounsfield unit, like it's about 10. So it could be a carcinoma, adrenal carcinoma, or adrenal mets, or it could be a pheochromocytoma. So this patient could have a possible lung cancer. So therefore adrenal mets, because given the history of the smoking. But before FNA, doing the FNA is not that recommended here. And even if you plan to do an FNA, you need to know whether the mass is suggestive of any pheochromocytoma, if the mass is a pheochromocytoma. So screening for the pheochromocytoma should be done. So you should ideally measure the free plasma nephrins, and you should rule out that. So and for the same reason, you cannot do the right adrenalectomy right now, because you need to know what exactly the mass is like. So if you perform the FNA before you confirm that it is a pheochromocytoma, it could result in a hypertensive crisis even. and DHEAS is not recommended here. And already the non-contrast CT is suspicious, and MRI won't add to anything, so doing an MRI will not be a sensible option here. So you have a 55-year-old woman coming with an incidental finding of an adrenal mass. So there is history of breast cancer in this patient, and she was cured with lumpectomy and radiation 10 years ago. There is no past history of any hypertension, but she has high type 2 diabetes mellitus. So she denies any change in weight, palpitations, sweat, tremors, or anxiety. And she has no Cushing-Oil features. BMI is 27, blood pressure is fine, and heart rate is fine. The abdominal CT shows a left 1.5 cm adrenal mass measuring 3 Hounsfield units. And after IV contrast administration, there is a 60% washout at 10 minutes. So which of the following is the next best step in the management of this patient? Is it a low dose 1 mg DST with plasma metanephrines, or 24-hour UFC, or a serum DHEAS, or will you do an FNAC, or will you go for the repeat abdominal CT in 6 to 12 months? So she doesn't have any Cushing-Oil features. She just has an adrenal incidentuloma. Her BP is fine. She's got only a history of type 2 diabetes mellitus. So here this is consistent with an adrenal adenoma, a benign adrenal adenoma, because it's an adrenal mass which measures only less than 10 Hounsfields on pre-contrast CT, and also contrast washout is more than 50% at 10 minutes. So if you look at the contrast washout, there is 60%, so it's more than 50% here. So it shows that it's quite likely to be an adrenal adenoma. So size of less than 4 cm again is also a favorable feature. So it all suggests that it's not a malignancy. So you don't need to FNA the left adrenal mass, because FNAC is indicated in METs from other cancers, but it doesn't show. It doesn't look like that her breast cancer has metastatized to her adrenals. So option D is out of question. So she also doesn't have any signs of virilization. So DHA is not necessary here. There is no history of hypertension, and blood pressure is normal. So she requires only a low dose suppression test and the plasma metanephrine testing, because for any adrenal adenoma you need to rule out as pheochromocytoma. So since she doesn't appear Cushing-Oil, only the LDST, the low dose dexamethasone suppression test is more appropriate, is suggested. So she doesn't need a 24-hour urine free cortisol, because the low dose will, it is more likely to identify this case of a subclinical Cushing's rather than the 24-hour UFC. And also, if you measure the UFC alone, you might meet a pheochromocytoma. So, the choice, the first choice is the right one. So the next question is about a 60-year-old man who is referred to you after finding of an incidental adrenal insulinoma because he was evaluated for an abdominal pain. So he doesn't have any weight loss or palpitations or anxiety, tremors or headaches. But he's got a hypertension diagnosed 5 years ago, and it's been really difficult to control now. So he's on multiple drugs like amlodipine 10 milligram, metoprolol. So the blood pressure is 160/98. Heart rate is fine. BMI is okay. So it does not have Cushing-out features. So the abdominal CT shows a 2 centimeter right adrenal mass on 5 ounce fields on pre-contrast image. So it shows that it's clearly benign. So the lab tests, I have not included the lab test here. So I will tell you about the lab tests. Sorry, I forgot to put that. So serum sodium and potassium is normal, even though the potassium is on the lower side. So he has also done a fractionated metanephrine, and the metanephrine is also low. So it's normal actually, the fractionated metanephrine, and the normetanephrine is also normal. But his aldosterone is found to be raised, and the plasma renin activity is found to be less. So he's got a raised aldosterone to renin activity, and this 1 milligram overnight dexamethasone suppression test is also normal. So this patient clearly has got hyperaldosteronism. Its aldosterone is basically raised, and he has got an incidental adrenoma. So what will you do next for a patient with incidental adenoma showing a increased aldosterone? Will you go for a right adrenalectomy? Will you discontinue the metoprolol and repeat the aldosterone and plasma renin activity? Will you evaluate the hormones again in 1 year, or will you do an AVS, adrenal venous sampling, or will you do a salt suppression test? So as you see, the CT findings are suggestive of a benign adenoma, and there is also a history of hypertension and hypokalemia, and the screening for primary hyperaldosteronism is positive. So his ARR ratio is more than 20. So he requires confirmation for his primary aldosteronism through the salt suppression test. So although the beta blockers can lower the plasma renin activity, it is not necessary to discontinue metoprolol in this case, because the beta blockers will not raise the absolute aldosterone concentration. So he needs, since he is positive for the screening test for primary hyperaldosteronism, he needs further confirmation. So it is inappropriate to wait for an year. And AVS and right adrenalectomy are not yet indicated, because he needs a salt suppression test first to confirm. So if the salt suppression test is positive, then you confirm the primary hyperaldosteronism. Then you could do the AVS to differentiate between a true aldosterone producing adenoma and a non-functioning adenoma associated with bilateral adrenal hyperplasia. So you could do like that. So the next question is that you are asked to evaluate a 6-day-old infant due to the concerns of ambiguous genitalia. So the delivery was by C-section, and the infant had a birth weight of 3 kilograms. So baby is found to have clitoromegaly, posterior fusion, and the urethra is at the base of the clitoris. So no palpable gonads. So lab shows that the glucose is on the lower side, but all other are fine. The electrolytes are normal, and the bun and the creatinine is normal. So you have a moderately big baby with features of ambiguous genitalia. So which one of the following test is a newborn screen to test for CAH? So which one is usually used to screen for CAH? Is it cortisol? It is 11-deoxycortisol or ACTH, 17-OHP or DHEA? So the answer is 17-OHP. So CAH is due to impaired cortisol synthesis due to defect in enzymatic pathway for the cortisol production. So it is mostly due to a mutation in CYP21A2. So that encodes for 21-hydroxylase enzyme. So defects in this mutation leads to impaired cortisol production, and also it will lead to an increase in CRH and ACTH. So this will result in increased accumulation of the precursor to 21-hydroxylase. The 17-hydroxyprogesterone levels will be increased due to the increase in ACTH. So this will consequently increase the adrenal androgens and DHEAs and lead to virilization of the female if the female fetus in utero. So it affects males and females equally since it's autosomal recessive. So males do not have any physical signs suggesting CAH at birth, but they can have a life-threatening adrenal crisis of hyponatremia, hyperkalemia, and hypoglycemia. So the 17-OHPG levels can be a useful tool to screen for the CAH. So but the limitations are if you do it very early, like in the first 24 to 48 hours, it could be elevated. And also if they have been on antenatal steroid cover for premature lung, it could be falsely elevated. And also in a stressed and sick infant, it could be elevated. So that needs to be kept in mind. So the last question is like a 70-year-old woman, a man with a history of 7 cm adrenal carcinoma, has high-grade features and local invasion. So he was operated and started on mitotane, but 3 weeks later he complains of mild abdominal pain and lethargy. So LFTs are okay and the serum potassium is low and serum sodium is normal. So what is the next step? Will you stop the mitotane? Will you arrange an ultrasound for the hepatobiliary system, or will you start the hydrocortisone high dose 30 to 40 milligram, or will you do a prednisolone 5 to 7.5 milligram daily? So adjuvant mitotain is usually used for the adrenal carcinomas. But the problem with the mitotain is that yeah, it could induce the hepatic cytochrome P450 enzyme. So it could lead to an increase in the metabolism of the cortisol and cortisol binding globulin. So they will need increased doses of glucocorticoid replacement to prevent the adrenal insufficiency. So higher doses of steroids are required. So that's why we start with the high dose hydrocortisone, 30 to 40 milligram. We don't use the prednisolone usually because the hydrocortisone will have the mineralocorticoid cover as well. So that's it for today, guys. So I'll meet you up with other questions in the next session. Thank you.